Okay. Okay.
And we're recording.
Good. Good. So, good morning, everyone. This program is sponsored by Home Haven and our Health and Wellness Committee. And we're delighted to have Dr. Kellner with us. In terms of any particular housekeeping issues or tech issues, I will be getting off the Zoom and leaving you all to the program. So you can refer to Rick Allen if you have any issue with your tech or whatever. I'm going to be getting off. So now it's my pleasure to, well, first let me just mention that Pat Allen, who is the chair of the Health and Wellness Committee, pulled this program together. Hey, Pat, give us a wave. Okay. Thank you so much. And Dr. Phil Pierce is a member of the Health and Wellness Committee. So go ahead, Phil.
Okay.
Take it away. Thank you.
Thank you.
Thank you, Laurie.
Dr. Kellner, welcome again on behalf of the Home Haven. And just briefly, Dr. Kellner is a graduate of UConn School of Medicine and has been practicing urology for 15 years in Southern Connecticut. So very experienced and with a specific interest in benign prostatic hypertrophy, which is his topic today. And just in addition to, he is board certified in urology, trained in New York City at Mount Sinai and at Sloan Kettering. So very qualified and very grateful to give us an hour. I know you have a hard stop for a 2 o'clock appointment, so we'll respect that. So thank you again for your time today.
Thank you for having me. Let me try to share my screen. It might be a good idea while I'm presenting just to mute your own screens so there isn't feedback for everybody. And then if you want, we could just save the questions for the end. I'll leave time for that. So let's see. Is this coming into view here with you? Okay. All right. Are you seeing my title slide, benign prostatic hypertrophy? Okay. All right. And did it advance to a cartoon slide? Okay. Yeah. All right. So let me get started. So, all right. So today we're going to be talking about benign prostatic hyperplasia, which is one of the most common reasons why I see patients who come to the office. We're going to talk about what the prostate is, why the prostate starts to cause trouble, and what's the evaluation of an enlarged prostate, and we'll discuss some of the treatments. So let's take a look at this picture. I think most of you are probably familiar with this scene, pre-COVID days, maybe at the theater, baseball game, where the men are lined up at the toilet. And the guy in the front, I'll try to move my mouse here. This gentleman here, he has urinary hesitancy. It's taking him a long time to get his urine stream started, and he has a slow stream. The second person behind him. Okay, if you don't mind, let's put your computers on mute, if that's okay with you. Thank you. The second guy has incredible urgency. He's got his legs crossed. He doesn't want to have an accident. The next guy behind him, he's got urinary frequency. He's been to the bathroom about 4 times already during this movie. And the other guy behind him is exhausted because he's been up 4 or 5 times at night to urinate. And these are typical people who have BPH. So let's talk about what the prostate is. The prostate is part of the genitourinary system. So it's part of the genital system. It produces the fluid that is in the semen. It's also part of the urinary tract. The bladder is above the prostate. The bladder stores urine. And then when you urinate, the urine travels through the prostate and out through the urethra, which travels through the penis. And the prostate is usually about the size of a walnut. I'm going to go to the next slide. In contrast, this is benign prostatic hyperplasia. You see this whitish tissue that's represented here has compressed the urethra. And this is a benign growth of tissue that continues to grow. We don't know exactly why it happens, but by compressing the urethra, it's making it more difficult to urinate, and it leads to a wide range of urinary problems. Now, benign prostatic hyperplasia, just to correct Dr. Pierce, he said hypertrophy. The actual term is hyperplasia. It's increased number of cells that form. Hypertrophy means the cells are getting bigger. Hyperplasia is there's increased number of cells that form. And it's a histological diagnosis, which means that you look under a microscope and you can see there's more cells than they're supposed to be. And the prostate is made of smooth muscle, and it's made out of glandular tissue, and glands are what produce fluid, and that's the semen. Now, there's two components to benign prostatic hyperplasia that cause problems. There's a static component, and that's just pure size of the tissue. The hyperplasia of the prostate narrows the urethra. And then there's a dynamic component to the symptoms, and that's because there is smooth muscle tone within the prostate, which could further obstruct the urethra. Now, the urinary symptoms are often divided into two categories: irritative symptoms and obstructive symptoms. Irritative symptoms are the frequency of urinating, urgency to urinate, nocturia, which is getting up at night to urinate, and then obstructive symptoms would be a weak stream, an intermittent stream, that means the stream starts and stops, hesitancy, which is a delay before the urine will start to flow, and then also incomplete urinating, dribbling at the end of urinating, straining to urinate. Those are all obstructive symptoms. And people who suffer from BPH may have a variety of these symptoms. Now, it's very prevalent. By age 40, 8% of men have BPH. By age 50, 50% of men have BPH. And by age 80 to 90% of men will have BPH. And so again, with an aging population, this is one of the most common reasons why men come to the urologist. This graph simply shows that as people age, which is the x-axis here, we see an increase in the prevalence of BPH. And this is international studies that have been combined over many different years. And so it's well known in any part of the world that as you get older, you're going to have more evidence of BPH. And here shows that there's an increase in lower urinary tract symptoms in men as they age. So the light green shows that as men get older, they have a weaker stream. There's increased urgency noted in the blue bar as men age. Frequency is noted in the yellow bar, which increases as men age, and the green bar represents getting up at night. And all these things continue to get more common as people age. Now, the causes of BPH are poorly understood. We know that it happens as men age, and there tends to be a family history. So most men who have enlarged prostate will say that their dad had a prostate issue, or they have a brother who has a prostate issue. So there is a family trait that seems to happen. We know that the prostate is influenced by hormones, and we know that testosterone and a more potent androgen called dihydrotestosterone and even estrogen can all impact the growth of the prostate. And there may be even some dietary factors that could affect prostate. Now, I mentioned before briefly about the physiology of the hyperplasia. And typically what happens with prostate cells, there is a proliferation of cells, but there should be a balance of growth of cells and cell death. When there's an imbalance, then you're going to have an increased number of cells, which leads to hyperplasia. And again, the prostate wraps around the urethra gets compressed, the urinary outflow is compromised, and the bladder then has to work harder to push out the urine. That leads to changes within the bladder and decreases the efficiency of bladder emptying. Now, this is a small movie. It's basically showing how cells divide, and that's hyperplasia. And then you'll see black cells. That is controlled cell death called apoptosis. So there's a balance between cells that are growing and cells that are dying. And in hyperplasia, there's an imbalance where you're going to have increased number of cells forming, and you're not going to be having as much apoptosis, which is programmed cell death. And this is an illustration that basically shows how hormones may influence. So here we have testosterone, which is the major male hormone. And that hormone gets converted to something called dihydrotestosterone, which acts on prostate cells, and that creates replication of the cells. The prostate starts to grow, and then the bladder will start to have changes because of that. Now, this slide represents that there is no correlation between the size of the prostate and the symptoms. And patients will come to me with urinary symptoms, and I'll tell them, I think it's BPH, and they'll say, no, the primary care doctor examined them, and they said the prostate's normal size. And I'll say, well, it's probably still BPH, okay, because it doesn't matter how big the prostate is. And these bagels, or you could use donuts, represent the prostate. Here on the left, we have a small bagel, which represents a small prostate. And as you notice, in the middle of this small bagel actually has a very tight bagel hole. all right? And this is how the prostate could grow. The prostate could grow internally, closing up the bagel hole. And so a small prostate could have horrible symptoms. Here on the right side is a large bagel, and this could represent a large prostate, but you notice the large bagel hole. This person, if this was their prostate, would probably have no trouble urinating, even though the prostate is very large. So it doesn't matter how big the prostate is. And when you have a rectal exam with a finger and you're feeling the size of the prostate, you cannot tell what the inside of the prostate feels like. In other words, if you're touching the outside of a bagel, you can't tell how big the bagel hole is. So there are multiple complications that happen because of BPH and the symptoms that go along with it. It can interfere with your daily activities. It could affect your quality of life. It could lead to worry and embarrassment. And it's associated with increased risk of sexual dysfunction. There are more serious complications of BPH. This picture here represents a bladder, which is very trabeculated. These lines are extra muscles that have formed. And this here in the middle is actually a bladder stone that formed because this person's not emptying their bladder well. And the minerals that are in the urine precipitate and form stones. And some of the potential complications of BPH that are more serious are urinary retention, impairment of kidneys. So if the pressure in the bladder is so great, it can actually go up to the kidneys and injure the kidneys. Urinary tract infections can happen. So if you have stagnant urine that's in the bladder and it's just not emptying well, if the bacteria get in there, you're more prone to have infections. Enlarging prostates are more likely to bleed. They're very vascular, and then you may see what's called gross hematuria, which is blood in the urine. I mentioned bladder stones. The bladder can decompensate with time, and there's also something where you could have incontinence because the bladder's so full it may just start to leak. Here's an illustration that shows some of the changes that can happen. So at the bottom of the diagram this picture is a prostate which has enlarging lobes. The bladder, which should be nice and smooth wall and relatively thin wall, is now very thick because the muscles have to work harder to push out the urine. These are bladder diverticulum. These are pockets that have formed because there's such high pressure that the lining of the bladder has protruded through the muscle and outside the bladder. It's similar to an inner tube being forced out of a tire. And these diverticulum could become massive. And here we have swollen ureters that drain the kidneys. That's called hydroureter, or swollen kidneys, hydronephrosis. And that's happening because of back pressure that all backs up because of the prostate problem. This X-ray shows some white substance here in the middle. This here, where the arrow is pointing, is a massive, massive bladder stone that's formed that fills the entire bladder. And this person probably suffers from severe BPH. And here's just another illustration of how the urinary tract could decompensate, where here on this side, you have a very thick wall bladder because it's working very hard and that pressure went up to the kidneys. And over enough time, once you have developed urinary retention, you could have a decompensated bladder, which is going to become very large and flaccid, and it's not going to be able to contract. The muscles will no longer work. This person will have urinary retention and will need a Foley catheter, which is a catheter that goes to the penis. I'm going to show you a few cartoons here. Here the prostate is growing. It's squeezing the urethra. And you can see here that the bladder is full. It's trying to empty. It gets very full. And there's a few of these that we're just going to go through. The bladder is very full. It's trying to push the urine out, but it's pushing against an obstruction here because there is tone in the prostate because the smooth muscle and the prostate is enlarged. And it's not going to allow the urine out very easily. And the bladder fills, it contracts, but it only empties part way. We see a very slow stream, just a trickle. And the bladder really never empties. It just kind of fills, empties partially, fills again. So this person would have what's called an elevated post-void residual or urinary retention, incomplete bladder emptying. There's different ways to describe it. Here's a more severe picture where the bladder is very, very full. It's emptying partially. And it's going to turn to a green color representing an infection. It's going to change in just a moment. And there's an infection that's set in. Here he's got some bladder stones. And here's a tumor that formed. And so maybe there's a higher risk of even developing tumors in a toxic environment. So when you go to your doctor, or if you have a urologist, there's going to be an initial evaluation. And with any good medical evaluation, you start by assessing a full history, and you'll assess other medical comorbid problems. other things that could mimic BPH, and we'll talk about that in a second. You also want to know about past surgical history, and specifically if I'm a urologist or if your primary care doctor is focusing on your urinary health, he's going to ask about specific voiding problems. A physical exam is going to happen. You'll feel the bladder, see if it feels full, and a digital or rectal exam is part of the evaluation, as well as a neurologic exam. This is an illustration of when you have a prostate exam. There's a glove finger that goes into the anus, into the rectum, and this is how your doctor feels your prostate. Through the rectal wall, this is the rectum, you could feel the back of the prostate. And with that exam, you could feel the size of the prostate, you could feel for tumors, you could feel for possible signs of infection. But you can't feel the whole prostate, so you can't really tell how big the prostate is because the prostate may be growing upward towards the bladder. You can't feel it. Some of the medical issues that may be uncovered while you're being evaluated for urinary symptoms could be a neurologic problem affecting the bladder, or uncontrolled diabetes, a urinary tract infection, a urethral stricture, that's a narrowing in your urethra, which could mimic symptoms of BPH, kidney stones or bladder stones, bladder cancer, and certain medications could all lead to urinary symptoms, especially things like diuretics, things that make you produce more urine. Part of the evaluation is doing a urinalysis, looking for infection, also looking at to see if there's glucose in the urine, which could be a sign of diabetes. If there is concern about blood in the urine, or if there's a smoking history, sometimes a urine cytology would be sent, and that looks for possible cancer cells in the urinary tract. A PSA is sometimes appropriate to check while you're evaluating for enlarged prostates. And sometimes you check a creatinine, which is a measure of the kidney function. Additional tests that the urologist may do would be what's called a cystoscopy, and that's where we look in the urinary tract. This first illustration is what it looks like inside the male urethra. And then this next illustration is when you're in the prostate, starting to go into the bladder. And this is, you have to take my word for it, this is an enlargement of the prostate. This is an abnormal bladder that I'm pointing to here. These are called trabeculations, which are extra muscles that have formed. And this is a large ball of prostate that's protruding up into the bladder as well. And so there's a variety of tests that the urologist may want to order that's specialized to further evaluate. There's a score called the International Prostate Symptom Score, also known as an AUA symptom score, which is 7 questions scored between 0 and 5 in order to assess your urinary symptoms overall. By adding up those numbers, the highest score you would have would be a 35. You could be categorized. So if you score between 0 and 7 with those questions, you'd be considered in the mild category. 8 to 19 would be moderate, and 20 to 35 would be severe. Now, based on the symptoms, whether mild, moderate, or severe, there's different treatment options. Mild symptoms could be that you would just have observation or watchful waiting. Moderate symptoms may prompt minimally invasive procedures that can help, or medical therapy. And then for severe symptoms, you may need a combination of medical therapy and more aggressive surgeries, and we're going to get into those treatments. Now, this is busy slide here. It's just showing some of the main categories of how we treat BPH. Watchful waiting, medical therapy, which we'll talk about, different treatments that can be done in the office, and then procedures that can be done, but they'd have to be done under anesthesia, either in a surgery center or in the hospital. In general, as you go through treatments being from conservative to more aggressive, so going from watchful waiting to drugs, prescription drugs, to surgery done in the office, to laser surgery, to traditional surgery, we're going to see that there's more invasiveness as you moved from left to right. And with more invasiveness, we also have more effectiveness. So the more aggressive you are with the treatment of BPH, the better it actually works. Now, the treatment of BPH can be done by your primary care doctor. They'll often start the treatment, but decisions could be made between the primary care doctor as well as your urologist if you're referred. Now, talking about watchful waiting or active surveillance, there we just review how the patient is urinating. They probably have mild symptoms, but you don't need to do any particular treatment. There are some medical, or I should say behavioral changes that could help, dietary changes, such as maybe decreasing less fluid before you drink less fluid before you go to bed, having a low salt diet, decreasing caffeine and alcohol intake. Those are all things that could help with urinary symptoms. without having to take any sort of medication. If you're diabetic, having your glucose under control is going to help you with some of your urinary symptoms. Now we're going to talk briefly about some of the medications that are used for prostate. We're going to talk about alpha blockers. We're going to talk about 5-alpha reductase inhibitors, and then the combination of both of those medications. So alpha blockers, you may have heard of, or maybe some of you take, or your friends who take. Those would be medicines like Flomax or alfuzosin, Rapaflo. There's a whole variety of different medications. And the way those medications work is they interact at the bladder neck and the prostate to relax the muscle, the smooth muscle. And these medications work rather quickly, sometimes even within a few hours, and certainly within a few days, there's going to be relaxation of those areas and the urine will pass more easily. So it is a very effective medicine for many people. And the nice thing is it turns on and off rather quickly. This is a list of some of the medications in these categories: terazosin, doxazosin, tamsulosin, alfuzosin. Some of the medications have to be titrated, which means you start at a low dose and you work your way up to a higher dose. And some of the medications are simply one dose. So again, the benefit of this type of medicine is there's rapid improvement of urinary flow. It reduces the symptoms of BPH, but there's a lot of side effects. And some of those side effects could be fatigue. There could be orthostatic hypotension, which means that your blood pressure falls when you stand up. That could lead to dizziness. And so we certainly are concerned about our elderly patients who take medications like this. And so typically we do tell patients who take this medicine to take it before bedtime. It can lead to problems with erections. It could lead to retrograde ejaculation. That's one of the largest complaints that we get from people who are sexually active, that they'll see less ejaculate when they take the medication. Rhinitis is going to be a sense of stuffiness in your nose when you take the medication. And those are the most common ones that I pointed out. So now we're going to talk about a different type of medicine called a 5-alpha reductase inhibitor. Those are medicines such as Proscar or Avodart, also known as finasteride or dutasteride. Those medications work hormonally to treat BPH. And what it does is it prevents the conversion of testosterone, dihydrotestosterone, which is a more potent male hormone. And dihydrotestosterone is what acts on the prostate to make it grow. And when you block dihydrotestosterone, you stop the prostate cells from proliferating, and you will have actually a decrease in the angiogenesis, which is the blood supply to the prostate. So by taking the medications such as a 5-alpha reductase inhibitor, you'll actually get a 30% reduction in the average, a 30% reduction in the size of the prostate. The problem with a 5-alpha reductase inhibitor is that it does not work quickly. It takes about 3 to 6 months for it to work. All right, so it does not turn on and off quickly like the other medications I mentioned. There are a lot of side effects with this medicine, especially in men who are sexually active. The medicine could lead to impotence, decreased libido, reduction in the semen, and also it will decrease the PSA levels by typically about 50%. And so there's a certain fudge factor you have to use in interpreting the PSA if you've been on this medicine, where you have to multiply by 2 in the future. In general, medical therapy is very effective for many men, but 30 to 40% of men will discontinue medical therapy within 12 months of taking it for various reasons. It could be limited efficacy, side effects of the medicine, or patients who are just simply non-compliant with medications. Now I want to talk to you about surgical intervention of BPH. Now, surgery is recommended in patients where BPH causes the more severe problems, such as problems with the kidneys, retention of urine, where patients cannot urinate. Those are situations where someone would need to have a catheter placed. Getting recurrent bladder infections, bladder stones, hydronephrosis, which is swelling the kidneys, or blood in the urine. Those are all reasons to consider doing surgery on the prostate and moving beyond medication. Now, again, this is a busy slide, but really what it comes down to is you can categorize what are the appropriate treatments for prostate based on prostate size. So small prostates have a certain procedures that are important. Average size prostates have another group of procedures, and large prostates have another group. And so this is the urologist is familiar with these things, and the urologist usually has several different treatments that they're familiar with and can offer based on the size of the prostate. Now, this illustration is of a TURP, which is often called the gold standard treatment for BPH. Many men will refer to this as a roto-rooter. And what we do with TURP, this is an old slide. We use cameras instead of sticking our eyes against the scope. Now we can use cameras and have our eyes looking at a monitor instead of next to the scope here. But looking through the scope, we can see the prostate, which is blocking, and there's a little metal loop which scrapes away the tissue and pushes the pieces of tissue into the bladder, which could then be washed free. So you go from having an obstructed prostate to a nice open prostate. And many urologists are familiar with this procedure. The problems with this particular surgery is it does require general anesthesia, and there are potential complications such as infection, bleeding afterwards. There's about a 20% chance of needing a second operation in the future. And rarely it can cause problems with incontinence, which is leaking urine, or impotence, which is problems with erections. Now, this picture here is a picture of an open prostatectomy, which was historically something a lot of urologists used to have to do, but with new technology, it's very rare to have to do this procedure. But for very, very, very large prostates that are over 100 grams, and a normal prostate is 20 grams, it's not easy to do a TURP, the roto-rooter that we mentioned, because the prostate is simply too big. And an open prostatectomy is where you make an incision over the lower abdomen, and then you make an incision opening the bladder. And here you see the urologist has a finger, and he pushed it down into the prostate, and he basically pulled out the inside of the prostate, just like you're peeling an orange, the inside of an orange out. And the problem with this surgery is very invasive. You have to heal from your incisions. You're usually in the hospital for 5 days. There tends to be a lot of bleeding. And so it takes a long time to heal from the surgery. So we don't do a lot of the surgery because we have better ways of doing this operation. I'm going to get into that. And actually, one of the surgeries that I do has replaced this. And I'll explain that in a few minutes. Because of the desire for people to be able to have their prostates treated, but they don't want these more aggressive treatments, we have a lot of procedures that have formed that are referred to as minimally invasive techniques for the treatment of BPH. And I'll briefly touch on some of them, and this is just a list of some of the different treatments, but there are treatments that can be done that are less invasive. Here's one illustration of using a laser. This is actually a green light laser, where you vaporize the tissue. So instead of cutting it away with the metal loop like I showed with the TURP, you take the laser energy, which is very hot, and it burns the tissue away, vaporizing it. So if you look at the three pictures on the bottom, this is beforehand. There's the pre-op image where you see the tissue obstructing the inside of the prostate. And post-op, you have the open cavity, and you see it's nice and dry because the laser is good at stopping bleeding. And after 3 months, you have a nice, healthy mucosal lining over that raw area. And so this is one of the options. This would have to be done under a general anesthesia still. Another procedure that I offer, and several urologists actually offer in Connecticut, is a procedure called the Urolift. This is a procedure that actually I do right in the office. I actually did 3 of them in the office yesterday. And with the Urolift, you're not cutting any tissue, you're not burning any tissue. You're simply putting implants in the tissue that move the tissue out of the way and hold it in an unobstructed configuration. So here on the left, you have a blocked prostate. Here's the device, which basically puts an implant in. And the way the implant works, there's a clip on the outside, a suture, and the clip on the inside. And here we have, all the way to the left is before, all the way on the right is after. We have a nice big open channel that's formed after they put 4 clips in the prostate. And this procedure takes about 5 to 10 minutes to do under a local anesthetic and a little medicine to sedate you. Here's a short clip of the actual procedure, still in animation. So you push the prostate tissue out of the way, a needle comes through, it puts a clip on the outside, a second clip is put on the inside, and it holds the tissue out of the way. It's almost like putting curtain pins in. It holds the tissue out of the way. So again, we push the tissue out of the way and we pin it out of place. And there it is, it's held in an open fashion. And there's a before and an after picture. The picture down below is before and after, nice and open, and this person is going to urinate much better. And I believe Urolift is now advertising on TV, so we have a lot of patients asking about it. Now, talking about the Urolift, that's a minimally invasive procedure, but it's questionable. The question is, how long does it last? Well, when the procedure was approved by the FDA, there was a study called the LIFT trial, which looked at this procedure over 5 years, and they found at 5 years, there was a 13.6% retreatment rate. That means that 84% of people are still doing fine after 5 years and do not need other treatment. And so the Urolift, even though it's minimally invasive for the right person, it seems to be a durable treatment. The thing about the Urolift is there is a period where you may have some irritative symptoms. PUL stands for prostate urethral lift. That's the same thing as a Urolift. And 34% of patients will complain of some burning when they urinate after the procedure. 26% of people will have some blood in the urine. 18% will have pelvic pain. 7% of people will have urgency. 4% of patients may have urgency incontinence where they leak a little bit because they have to go so urgently. And 3% of people could develop an infection after the implants are placed. And most of these symptoms are transient. They usually last just a few days, and on some occasion, maybe a few weeks. The nice thing about the Urolift for men who are sexually active, there's no problems with ejaculation after the procedure, and there's no problems with erections after the procedure compared to all the other treatments where there tends to be some problems with erections and ejaculation. So the Urolift is a very nice procedure for younger men who are sexually active and for older men who want to avoid the operating room because we could do it in the office. Another procedure that's become rather popular is called the Resume procedure. And the Resume is where you put steam energy into the prostate, and this could also be done in the office. And by putting high energy into the prostate, it injures the tissue, and over time, the tissue gets reabsorbed. It doesn't work like the Urolift, where you have almost immediate opening in the urethra. It does take probably 8 to 12 weeks before you start to see an opening. Now, the procedure that I'm very proud of that I'm offering at Yale is called the HOLEP. It stands for Holmium Laser Enucleation of Prostate. Now, the HOLEP is where you use laser energy and you use your scope to open up the prostate tissue, but it's not like the TURP where you come through the middle of the prostate. You come to the side of the prostate tissue that's obstructing, and you peel out the inside of the prostate like you're peeling an orange. And there's very little bleeding with it, and you can do very large prostates. So this third surgery I do with the laser is equivalent to that surgery I showed you called the simple prostatectomy, where the surgeon had made the big incision and had his finger going through the abdomen into the bladder. I'm doing that same surgery now using a laser without any incisions, and I could pretty much do any size prostate. And the patients are actually often going home the same day or the next day. And we'll talk about that in a little bit. Let me just go to the next slide here. Okay. All right, here. So here's an illustration. So we talked about that orange idea. So here you're peeling an orange using laser energy. Very similar to what we're doing with the prostate. We take all that tissue, we peel it, we push it up into the bladder, and then we have a special instrument called a morcellator, which chews the tissue up and takes it out of the bladder. And without any incisions, we can remove a lot of tissue. I've done prostates up to 300 grams, when again, a normal prostate is 20 grams, and with very, very little bleeding and the patient being in the hospital for just about a day. So HOLEP, again, holmium laser enucleation of the prostate, is now arguably the gold standard of treatments. The only thing is most urologists don't know how to do it because it's hard to learn how to do and you need special equipment. But when they compare the HOLEP to the other types of surgery, it's basically better in every category. I'll show you just a brief illustration because I think you might find it interesting. This is an actual surgery. This is a prostate that's very obstructed. And this is what a HOLEP looks like. So this is not normal prostate, take my word for it. This gentleman has a bladder stone, and using the laser energy, that's the bladder stone, we could break the stone up using the laser as the first part of the surgery. And that stone was removed. Here we are getting into the prostate, we are opening up the tissue, and we're trying to get out to the layer on the outside, which is the capsule, and that's like the peel of the orange. And once we have everything peeled, we basically move that tissue and we start to move it up, and we push it up into the bladder. And you're going to see, we're going to follow the orange peel. That white tissue is the orange peel, and we're following it, and we're moving all the orange pulp, which is prostate tissue, up to the bladder, and we're about to release it now into the bladder. And you can see that it's kind of hanging there just by a little pedicle. And there's a big, large piece of tissue, and that's the inside of the orange that we're pushing into the bladder. And we do that all around. And here's another piece of tissue that's being moved. So you could either do it in sections or all at once. So the green is the laser, and that little light is where the laser is projecting. And here we are, we're freeing up the tissue. So everything to the left is being freed. To the right is the capsule of the prostate. And there we are, we left another piece of tissue. And now we're inside the prostate. There's no more obstructing tissue. Before you saw all that pink tissue that was blocking. Now we have this big, huge open cavity with minimal bleeding. And there's the free tissue right there that's floating in the bladder. And here's the morcellator. This is the instrument that chews the tissue up and it sucks it out of the bladder. And so you don't have to make any incisions to remove all that tissue from the bladder. And so these procedures, again, are very, very effective. And it's been pretty amazing for some patients. So in summary, BPH is a common health issue among aging men. It affects the quality of life and more serious health consequences. And there are many available treatments for BPH. We mentioned behavioral modification, such as decreasing caffeine, alcohol, drinking less before you go to bed. We talked about different medications like alpha blockers, 5-alpha reductase inhibitors, or you could actually take them in combination. And we talked about different surgeries that can be done both in the office and in the operating room. And it's important to consider the patient and the prostate factors when choosing the best option. We have to look at the symptoms that you're experiencing, the anatomy. We got to think about the efficacy and durability of the procedure, other comorbidities that a patient may be experiencing to see if they're safe to undergo these procedures, and think about the different side effects of the different treatments. And together, the patient and the urologist can decide on what the right treatment is. So here's before the urologist, again, a line of people waiting to go, and this gentleman couldn't wait long enough and he had an accident. And then after the urologist, this gentleman is saying, sometimes I think this is the best part of my day. And so at this point, I could take any questions. And we have about 15 minutes to go over things. You can take yourselves off of mute if that at this point.
Yep. This is Phil again, and I'll start out while others are composing their questions, perhaps. Could you comment as to any risk, since many people will have a prostatic carcinoma, when you go in and either laser through those or morcellate those, is there any increased risk of spread of that malignancy during the procedure?
Right. So let's break that down into two parts. Okay. If someone has prostate cancer, but we didn't know about it, and we do a procedure where we send tissue, sometimes that's when we make the initial diagnosis. There's no belief that we're going to be sending prostate cancer throughout the body or causing it to metastasize. The way that we diagnose prostate cancer currently is with a transrectal ultrasound and sticking a needle through the rectal wall into the prostate. And that has never been shown to spread prostate cancer. Mm. The other issue is if someone has a known prostate cancer and it's been treated, say with radiation, you have to be very careful on doing any surgeries because the chance of developing incontinence is a lot greater. So you have to kind of modify what type of work you would do on someone who's had radiation. If someone has prostate cancer, but it's a non-aggressive type and it's just being treated with active surveillance or watchful waiting, most of these procedures can be done. Because really the problem that most of these men are facing is their BPH, which is actually affecting their quality of life. And the prostate cancer is kind of an incidental thing, which is never going to hurt them.
Okay, thank you. Rick, I think, can you see anyone with hand raised? Is that?
I don't see the grid view here. Dr. Kellner, if you get your slideshow off, I think maybe we'll see the grid view again. Do you see the grid view?
Let's see.
I don't see any chat comment. If somebody wants to ask a question, raise your hand or go in chat and identify yourself.
Mm-hmm. I see Myra. Why don't you go ahead and unmute and then go ahead and ask then. Myra?
Yeah. So on the HOLEP procedure, are there statistics comparable to the first one you showed us? When how long it lasts?
Mhm. So the HOLEP, which is the kind of the revolutionary newer procedure that we do, compared to the TURP, it lasts longer. The chance of needing another surgery after the HOLEP is probably about 1 to 2%, because you're removing all the tissue inside the prostate, versus the TURP, which was always called the gold standard. The retreatment rate's probably almost 20%, because you're never removing all the tissue. And it's almost like you're digging a hole in the ground. And then, once you dig a hole, it's difficult. And then the sand starts to fall back into the hole. That's what happens with the TURP, because you create this large opening, but then all the tissue behind it just settles in and takes the place of where that previous tissue was. So with the HOLEP, that doesn't happen, because you're removing everything all the way out to the capsule.
Perfect.
Thank you.
Louis. Unmute, Louis, you're muted.
There. I seem to be fairly typical of my age, which is 81. I've just had a ultrasound, which shows that each of my kidneys has a small stone in it. I've had an issue with some urinary retention, and one of the things she measured was how much was left after I peed, and it was a substantial amount, 20% or so. The other thing about it is that I've been taking tamsulosin for about 2.5 years. With all this going on, I looked at your range of indicators, and I haven't gotten any kind of word from my urologist or my primary that there's anything really wrong about what I'm experiencing. It's just the way I am at my age. And so part of what you've told us today was so graphic, it was alarming. The rest of the time, I'm wondering if no news is good news.
Right. So what you're experiencing is maybe affecting your quality of life. The way you're urinating. You're not really expressing, and I don't want you to be too personal with your health in this format, but if you don't have any of those absolute indicators to do surgery, such as developing recurrent infections, developing retention, having bladder stones, having bleeding, if you're not having any of those absolute indications, then you don't necessarily need anything done beyond what you're currently doing. But if you want your quality of life to be better, if you want to sleep more, if you want to be able to drive in your car from here to New York without having to look for 3 bathrooms, if you want to be able to watch an entire movie, then you may want to consider some of the different procedures. And again, not every procedure is as aggressive. So some things like the Urolift, which could be done right in the office, can give people a better quality of life in terms of their urinating without committing to a very large operation that needs to be done in the operating room. So if your doctors are going to listen to you. If you're not complaining, then they're not going to address it. But if you're bothered by your urinating, then you need to say something.
Thank you very much.
And it sounds like we would start with our primaries with questions and concerns and kind of describe to them what's going on, what we sense. And if they're savvy, they would refer us to somebody like you to figure out what particular treatment might be appropriate.
That's true. But I mean, if you have urinary symptoms, and see, the thing is, many men have these symptoms. Yep. But men don't talk about it. I mean, this is a format where everyone in this group is interested in their health. But a lot of men, they really don't want to talk about it, or they just accept it's part of aging, and they forgot what it's like. But if you took your 16-year-old self and then put your 80-year-old urinary symptoms on your 16-year-old self, you'd be like, what is going on? All right. But this kind of, the urinary symptoms creep up on you, and it doesn't mean you have to accept it. All right. Because I have patients who struggle to urinate, and they've been doing it for years. And not until they're tipped over the edge, where suddenly now they're in retention, and they come in with a catheter, and they're begging for something to be done, but they could have done something before they went too far, before they needed something so urgent and had to have a catheter put in. And most of the patients I do these procedures on say, why didn't I do that a long time ago? You know, why did I suffer and struggle to urinate for years and years? I should have done it a long time ago. So it's not for everybody. Again, I don't think anyone should be too aggressive with these things, but if it's appropriate, it should be considered.
I have a question. Can you hear me?
I can hear Steve.
Yes.
Okay, really two questions. The first one is frequent urination. What do you consider frequent, and when does it become a point at which you should, the patient, me or whoever, should consider some kind of intervention? That's the first. And the next question was that pinned process, the Urolift. What happens to that device over time? Does it float out? I mean, what's the permanency of the device that's in your body?
Okay, so urinary frequency, usually what's quoted is if you urinate more than 8 times a day, that would be considered frequent. So some of it is more subjective. You know, people will say, you know, oh, I urinate so often. I urinated 3 times today. Well, that's probably not frequency. All right, so it's really hard to say what frequency is. I think if you're bothered by it, then it's probably frequent. Okay, so you just have to have realistic expectations. But if you're drinking 3 cups of coffee a day and you're urinating a lot, you just cut back on the caffeine. I mean, you got to think about why are you urinating frequently. So there's not really a perfect answer for that. You asked about the Urolift, the implants. Those implants are permanent. What happens is once you've put them in, they actually get embedded in the tissue, and the lining of the prostate, which is called mucosa, ends up covering up the implant, and you don't see it anymore.
All right, thank you.
You're welcome.
What imaging device do you use most often before doing a hole-up? Is there?
So I'll pause this for a second. I'm doing a lecture. I'll be there in 5 minutes. In the office? All right, I'll be out in 5 minutes. Yeah. Sorry about that. Hello?
What imaging device do you use one to determine what it looks like inside the bladder prostate?
That's called the cystoscope. So that little video I showed,
Yeah.
That's a cystoscope. It's a camera that goes through the urethra, and it's attached to a camera.
So a person could be asking the urologist to do that.
Well, like the whole that'd be done in the operating room. Yes, the urologist would do that. That's done in the operating room. We can do cystoscopies right in the office.
Okay.
And usually we evaluate people in the office with a cystoscopy.
And is that an operating procedure that you have to set up a long time?
No, it's about a 1-minute procedure. We put numbing medicine in the penis. It's like a gel that lubricates everything. And then we pass the scope up, and we could see the prostate. It's either done using a video or just with the naked eye. It takes about a minute to do. It's similar to being catheterized if you've ever had to experience that.
I have a question, doctor. How long after a cystoscopy should one be experiencing pain upon elimination?
So for most cystoscopies, especially with the flexible scopes that we use these days, people probably would have some discomfort for about a day or so, where they might have a little irritation. But I wouldn't expect it to get worse and worse as time goes on. It should gradually continue to ease up. And many people have no symptoms at all after cystoscopy.
Well, let's say 3 days. Is that still in the ballpark for no cause for alarm?
I would say so, as long as things then start to get better. If they were getting worse, I'd be worried about like an infection or something.
All right, thank you.
Got another minute or two. Who's got another question? Well, thank you, sir.
Thank you, Doctor.
Dr. Kellner, this was very helpful, very informative. I think this gives me, at least personally, some focus on what I can chat with my primary and how to describe what's going on. And she can refer me over to you if she and I think appropriate to fix the problems.
That sounds good. I'd be happy to meet any of you personally in my office if you ever want to talk more about it.
Okay.
But thank you for having me. I appreciate it.
Good.
Right.
All right, so
Thank you.
I'm actually gonna go do a hole up right now.
How's your sound? Can you take the Zoom with us?
You guys want to come?
Maybe.
Thank you, doctor.
Thank you, Doc.
Thank you. You take care. Okay.
Very